It's a good time of year to go on a cruise. All right, I'm going to go ahead and share my screen and we'll get going. Everybody see that okay? All right, today we're going to talk about some Pacu stuff. So depending on where you go, the setup of each Pacu is a little bit different. You may be in a solo provider shop where you're responsible for pre-oping the patients, post-oping the patients, and everything in between. That's kind of gratifying, especially if you're in a smaller community, because you really get to know the people you work with and you're responsible for their total anesthetic plan. The good news, bad news is that you wind up having to manage a lot of things simultaneously. So instead of just showing up and doing your cases, you have to put a little bit of thought and planning into your day. And then you kind of have to evaluate what you have capability-wise for the nurses and support in the recovery room. Because if you're going into another case and you're the only provider there, you may have to manage issues simultaneously, which can be kind of hard to do sometimes. All right, today we're going to talk a little bit about kind of the flow of patients from the operating room to PACU. And part of that is just because you need to understand some of the terms, and part of it is because you need to understand the kind of barriers that come along with things. We're going to talk a little bit about how PACUs work and their functions and their lack of functions, because they can very quickly turn into a log jam in the operating room process. And that may just be a matter of physical structure, as in they don't have enough bed. And then we're also going to talk about things that may go wrong in the PACU from an anesthetic standpoint as well as a surgical standpoint. Because a lot of times, especially in those smaller facilities, the surgeon's long gone and you're responsible for dealing with a lot of the complications that may come along in recovery. And part of that may involve having the surgeon come back or having his partner pick up the pieces. There's some pretty set standards for nurse anesthesia practice. Part of those include care in the PACU. We're going to go through those because one thing you have to keep in mind is that the standards don't change just because the patient goes to recovery. So first of all, anybody that's had basically any type of anesthesia has to have appropriate post-anesthesia management. What that post-anesthesia management varies a little bit depending on what they've had done. So you'll see that sometimes you're held to kind of this vague standard that it's got to be appropriate, but you're not really sure what appropriate is. So if the patient's going to the PACU, they have to be accompanied by somebody from anesthesia. And what I mean by that is that you can't just finish the case and the nurse pushes the patient over to recovery. You have to be able to continuously monitor the patient and support them while they're being transferred to that recovery room. I think we've all met OR nurses. If you haven't, you'll very quickly see that they're not so much of a nurse anymore. Probably not who you want managing your patient if something goes wrong in the hallway. When you get to the recovery room, you're responsible for providing a report to the PACU nurse. And how this happens kind of varies from one place to another. Some places, the OR nurse will call report from the room to PACU. Some places, the anesthesia provider calls report. Some places, you actually hand them like a little piece of paper that's got the patient's information on it. Sometimes you will pass off a piece of paper when you get there. So it really kind of depends on the system and what their setup is. But there has to be some type of handoff from the anesthesia team to the PACU nurse. When you get there, the patient has to be continually evaluated in the PACU. So part of that is making sure that there's not an excessive number of patients being cared for by one nurse in the PACU. The maximum ratio is usually fixed at 2 to 1, but there is some variation to that depending on what state you're in and what kind of guidance they're following. And then the last part is a physician has to be responsible for the discharge of the patient from the PACU. Now, it says a physician, it does not say an anesthesiologist. So you may go through and evaluate the patient and determine they're safe for discharge from the recovery room, and then they go on to the hospital. You can be discharged from the recovery room and it not be the same as being discharged from the hospital. On the other hand, say you're in a single CRNA shop and the patient's being discharged home from recovery, somebody, usually the treating surgeon, is going to have to be responsible for discharging them home. And all that really means is that they're the ones saying they're acceptable to go home. They may know absolutely nothing about anesthesia, And usually what happens in those settings is they have delegated the anesthetic care to you. So you're responsible for making sure they're okay to go, and then they just sign off on it. So looking back through history, PACUs didn't exist for a long time after anesthesia came into play. In the 20s, the 1920s, they started off with several PACUs. And after folks started coming back from World War II, they realized that PACUs were kind of a need because patients weren't being carefully treated and evaluated after they had their surgeries done. They figured out this was kind of high risk for the patients. A study in the 40s showed that about 50% of the deaths in that first 24 hours were preventable. A large number of these deaths were happening in the recovery room or would have been caught in the recovery room. So after that, having a post-anesthesia care unit became the standard of care. So who do you see working in recovery rooms? It's a variety of folks. The kind of go-to or the foundation of a lot of those recovery rooms is going to be PACU nurses. Historically, these have been ICU nurses that got burned out or ER nurses that got burned out and then wanted a little bit more of a lifestyle specialty. So PACUs are generally, Monday through Friday, 7 to 3 jobs. So they're usually pretty quality nurses. There's always people that kind of fall through the cracks, but usually these are pretty decent nurses that have just moved on to have a little bit cushier life. Respiratory therapy plays some role in it. It partially depends on what type of facility you're in. If you're in a pediatric facility, they're a little bit more active than they are in adult centers or multidisciplinary centers. Usually their involvement consists of the same things they do the rest of the time, passing out neb treatments. The big difference that you see as far as in the recovery room is a lot more of our patients, especially those that are high risk for sleep apnea and obstruction, will come out and have to go on CPAP or BiPAP. So they may be setting them up on a facility CPAP or BiPAP, or they may be setting them up on their own, which can be kind of hard because there's so many different machines and models out there that it's a little bit more challenging to know how all they function. Anesthesia usually will staff larger PACUs. And what I mean by staff is that there's somebody responsible for covering that unit. So they deal with emergencies there, and then some places they're actually responsible for putting in the PACU orders. Other places, the treating provider may be the one that puts in the orders, and that person just covers the PACU. With that being said, they may also be covering other things. They may cover the airway pager, they may cover PACU, they may be covering the pain service. So it really depends on the size of the facility, what that other person is doing. And then on the other end of things, there's usually an intensivist or a hospitalist that's responsible for kind of cross-covering the PACU. So say, for instance, your patient was planned to be a day surgery, patient came in, was supposed to be going home. Because of something during their intraoperative course, they're going to wind up staying, so that hospitalist has to come down and see them. You will also see in kind of specialty or short stay hospitals, a lot of them are like orthopedics, that there may be a hospitalist that comes down and manages that patient for that 23-hour stay. But again, there's some degree of variation. The important thing is to make sure you know kind of the roles and responsibilities for that facility and how the handoff occurs there. And we'll talk a lot about that. So as far as like physical location, PACUs may be close to the operating room or they may not be. In a perfect world, they would be set up just across the hall from the ORs. In lots of places they are, but you'll see in other facilities, they're almost like an afterthought and you may have to travel quite a ways to get there. A lot of times what happened is the hospital had ORs on one floor, and then as they continued to grow, they didn't continue to grow PACUs. So you may have to actually take your patient and put them on an elevator and move them on, or it may be in another building. There's lots of things that kind of come into play. So you have to really think about that as part of your anesthetic plan and your wake up. If you're going a short distance, a lot of times we don't do any true quantitative monitoring. It may just be a matter of looking at your patient and make sure they're doing okay. If you're going to be going longer distance, usually the minimum standard is to have like a portable pulse ox, but sometimes you actually have to go ahead and put them on a monitor. Anybody that's going from the operating room to the ICU needs to be monitored at the same level they were before. And if you're ever in doubt, just make sure you've got a transport monitor available for you. Other things, like I said, a basic, make sure they're breathing. A lot of times evaluation of circulation is purely done based off of the vital signs you had when you left the OR and when you get to recovery. So with all those things in mind, you need to be able to address any issues that pop up. So, take some extra medication with you. A lot of times people will take extra propofol for sedation, for nausea. I usually recommend, call it an upper and a downer, but taking something to raise their blood pressure and something to lower their blood pressure. And then if you've had any issues intraoperatively, make sure you take medications to kind of deal with those. So for instance, if you know your patient was hypertensive during the case, one, make sure you've put in Pacu orders to address that. And two, also make sure that you're taking some more labetalol, esmolol, hydralazine, whatever you've kind of been using along the way. Also consider, if you have somebody with a somewhat unstable airway, you may take an oral airway with you. You may take a handle, a blade, and a tube. You may take an ambu bag. So think about all those things when you're kind of planning your trip to the recovery room, especially if it's quite a ways away. So when you get to the recovery room, the nurse is going to do a basic assessment, look at the airway. A lot of times patients will come out with an oral airway or a nasal airway. Some places patients will actually come out still intubated or with an LMA in place, and that's routine practice there. It's not necessarily wrong. I've just never really had, especially an LMA being the reason that I'm stuck in the room. So you're going to see quite a bit of variation there. Some places, especially while you're a resident, you never leave the room. So you'll do the case, and then another CRNA or an anesthesiologist will actually come transport the patient to recovery, and then they bring your next patient in almost immediately. It just depends on the setup and flow there. Other things for you to think about evaluating hypoxemia, because that's one of the biggest issues we deal with in PACU, and we'll talk about kind of issues here in a little bit. But, it can go all the way from having a patient on room air to somebody that's essentially on like a CPAP or a BiPAP mask. High risk patients are those that are obese, those that are over sedated, and kind of extremes of age, so over 60 or less than 6. When you get to the recovery room, one of the first things I do is make sure that I get the patient connected to the monitors. Almost every facility has you transport the patient on oxygen. So get them hooked up to oxygen when you get there, and then you can hook up your monitors. As far as monitoring standards, they're the same they were in the operating room. Some places will even do continuous capnography, which has proven pretty beneficial for detecting problems, especially airway obstruction or respiratory failure in those patients. So get your monitors hooked up. Some places the PACU nurse does it, some places you do it. Know what the facility practice is, because as trivial as it is, people get very territorial about things like that. You didn't hook up the pulse ox first, or, you were supposed to hand me the blood pressure cable. And it sounds really stupid, but some people really get bent out of shape about it. So when you get there, go ahead and reassess your patient, get the patient connected to the monitors, give the PACU nurse the report. The PACU nurse is also going to be assessing the patient at the same time you are. And then the patient's going to go through 2 separate phases of recovery. And we'll talk about kind of how those happen, where they happen, because one of the issues, like I mentioned earlier, is sometimes the PACU gets backed up and you may actually have to recover your patient in the room. So the standard for those 2 different phases doesn't necessarily change. Just where it's taking place does. So there's a lot of different forms out there, or formats, when you're giving a report. The big thing is just to make sure you're organized and that you've got everybody's attention. I know some people will just stand there and not say a word until they're spoken to. Other people are like yelling, screaming, snapping their fingers, clapping, trying to get everyone's attention. None of those are really acceptable. Just figure out what the pattern is for that facility. Make sure they're listening to you, because if you just stand there and start talking, they may be doing 50 other things and don't hear a word you say. So that's great. You gave a good report, but now you get to do it again. The other thing, and it's something people really struggle with when they first start off, is getting the pertinent information without telling them everything that has nothing to do with what's going on. So this is not telling them everything from your pre-op. And we're going to go over kind of some anesthesia specific stuff here in just a second. So this is an example of kind of an S-bar handoff. Like I said, make sure they're ready for report. Some places do a formal timeout before they start the handoff. So if the PACU nurse isn't ready or respiratory is not ready, you just stop. So during that, start off by verifying the patient. Usually it's done by looking at the computer, looking at the patient's bracelet, and if the patient's able to participate, them as well. And then discuss the procedure and the surgeon, any sort of pertinent medical history. So lots of patients have lots of medical history that has nothing to do with anything that's going on. So don't get the rambles, just tell them stuff that's pertinent to what's going on. Same thing with surgeries. They don't need to know every surgery they've ever had, just stuff that correlates with what's going on today. Any allergies are important to pass along. So from an anesthetic standpoint, the type of anesthesia, when people first start off, they get really bogged down on whether they had an endotracheal tube or an LMA. It doesn't matter. You will quickly figure out that nobody really knows what you do back in the operating room. It's kind of like voodoo. Especially when you start talking to like ICU nurses, they're like, "How did you keep the patient asleep?" And you're like, "I gave them gas." And they're, "Well, were they on propofol?" "No, I gave them gas." "Well, how does that work?" They don't really understand what you do and how you do it. So don't get too bogged down in the details, because a lot of times it provides confusion. You don't really need to tell them every medication you've given, as long as it wasn't pertinent to what was going on. So things to think about: antibiotics, analgesics, antiemetics. If you gave them a neuromuscular blocker, that they were fully reversed. Other things to think about, and lots of places now have a standardized computer charting system, so you don't get it so bogged down in it. But what IVs they have, where they are, and then any concerns, especially from an anesthesia standpoint with like the airway. Maybe he was a little bit of a difficult intubation. Hey, the brand new resident did it and it took a little while, so they're probably going to have a little bit of a sore throat. That way, when they wake up and they have a sore throat, they're not really surprised. Or, hey, he had dental surgery or facial surgery. There was a throat pack in, but he probably will cough and sputter with some blood. Or, he's a smoker, so he's got lots of secretion. Stuff like that is helpful to pass along to them. Pertinent things during the intraoperative period. So from a surgical standpoint, high blood loss, they poked a hole in something, things like that may impact what's going on in recovery. A lot of times these surgical events and concerns will be passed along by the OR nurse. But sometimes, they skim over things, or they don't realize what's important or what's not important. So if there's something important, please make sure it gets passed along. Any blood products given or labs drawn, if you happen to check a ABG while the patient was in there, please pass along, pertinent values from that. And then things to think about in the postoperative period. What do you anticipate for the patient? They're on HOMO 2, they need their own CPAP, BiPAP, what have you. Sometimes you will have postoperative orders that need to be continued, including infusions. So maybe I want to keep the patient's blood pressure less than 120. So with part of that, I want the patient to be on cardiac. It should already be in your orders, but a lot of times it's helpful to pass those things along. Any specific analgesic or sedations, again, should be in your orders, but make sure you pass it along. And then where's this patient going afterwards? Are they going home? Are they supposed to go to tele? Do they have to meet certain goals before they go home? Maybe this is somebody that had a vascular procedure done and they have to lay flat for 4 hours. So things like that, make sure you kind of pass them along. And this is kind of a simplified version of what I just showed you. This is kind of overwhelming and confusing, but when you're first starting off and you really need to think about things, this might be good. This is a little bit more about what you really need, things that are important to pass along. And then as I said, make sure that they have understanding of everything, and make sure they're okay with the patient. This is another detailed form. Sometimes you will see that these actually are either synced over from the computer, or maybe something that you write out. It just depends on the facility. Other places I've been, they had a like dry erase board that you would put some of this information on and pass it along. So know what the practice is wherever you go. When you go straight to the ICU, for a long time, this kind of fell apart. Again, things may vary from one place to another. Usually you'll call report to the ICU nurse. You may also call report to the intensivist. And then when you get up there, make sure you're talking to those same people. And then the other part is making sure the surgeon's involved in the handoff there. So if there are any postoperative issues, they can kind of address them. Now, if you're in a teaching facility, most of the times this is going to be the surgical resident, not the staff surgeon. So just know what the practice is there. It may also be that the surgeon is going to be cared for by the same team in the ICU that they were cared for in the operating room. So like maybe they're on the acute care surgery service and that's who staffs the surgical ICU. So they already kind of know what's going on, but maybe the operating resident is not the same as the ICU resident. So make sure that information gets passed along. From our standpoint, same thing. We've got to make sure that we pass off detailed information to the patients. A nurse, usually we do that over the phone beforehand, but if you forget stuff or things change, you can always do it when you get back upstairs. So phase one, this is the patient's initial recovery period. This is kind of I said intensive phase, but this is really when they get out there and they're looking for big issues that might have happened. Or when there's kind of a higher risk of things happening. Things can happen down the line, but usually it takes a little while for that to happen. So when they get out there, they're going to be on the same monitoring standards that you had in the OR. So heart rate, SpO2, respiratory rate, EKG, and then monitoring the airway patency. Most places for the first 15 to 30 minutes, they will be a one-on-one patient, but other places they're a two-on-one. So if you have a little bit higher ratio, you may need to think about, kind of high-risk patients. Maybe it's better not to send these patients out with an oral airway in place or things like that. If you have somebody that is still intubated, they'll make sure they've had neuromuscular return. And a lot of times, if they're still intubated, they will involve respiratory in their care as well. So when they get out there, vital signs for the first 15 minutes or every 5 minutes. After that, they go to every 15 minutes. So patients only have to stay in phase one for 30 minutes. And that's important for us to know because, say, for instance, phase one is usually where PACUs get backed up. So if they get delayed there, you may complete phase one recovery in the room. So basically what that means is from the time that you would be able to go to PACU till you hit that 30-minute period, the patient's in their phase one recovery. After that, you can transfer them to phase two. You may also have to do phase two recovery in the room. I've had patients before that I had to get the OR nurse to figure out how to print the discharge instructions, and I wound up actually wheeling them out of the hospital because we'd been sitting in the room that long waiting on a PACU spot. As PACUs have turned into overflow ICUs and the catch-all for lots of things, it's not uncommon for us to get delayed trying to get out to PACU with surgical patients. Some places manage that a little bit better than others. Some facilities will realize that they're kind of in a critical bed situation already and start canceling elective cases. Other places realize that that's kind of their money source to get those cases done. So they just move on, and then, whatever happens, happens. It's kind of frustrating for us because a lot of times we wind up doing things we see as below us, like being that PACU nurse. But it's not bad. You sit in the patient's room and, just hang out. You were already in there for a couple hours. What's another 30 minutes to an hour? The one kind of disservice for the patients is that they're going to be continued to bill anesthesia time. So, good for us. We're making more money for the department. Bad for the patient. They keep getting billed that same level of care. So just as the standard intraoperatively was to keep the patient's vital signs within 20% of baseline, that continues to recovery. Make sure you're appropriately charting the vital signs. So we have this habit of trying to make everything look rosy when we get out to recovery. If you get out there and your patient was cold the whole time, or they get out there and they're cold, be honest, they're cold. Sorry things didn't work out. Like we talked about the other day, make sure you've done everything you can to get them to that point. If they started off really cold, you're probably not going to be able to fix everything while they're in the operating room. Same thing with low blood pressures. If you have hemodynamic issues, don't walk away from that patient. You need to stay there and address those things before you move on. I don't care how busy you are. Do not walk away from an unstable patient just because you've got another case to do. So after they go through that phase one, they're going to go on to phase two. So think about phase two as kind of like the growers and feeders of PACU. This is where they're getting something to drink, they're getting dressed, they're taking out their IVs, that sort of thing. When they're there, they're still monitored by a nurse, but it's usually a lot looser ratio. So you may have like one nurse to every 4 or 5 patients. They'll come through and document a couple sets of vital signs, get the IV out, stuff like that. You will sometimes have patients that only get sedation, and they don't have to go to phase one because they didn't have a general anesthetic. So they may get just a couple milligrams of Versed, and they're able to bypass phase one and just go on to phase two. So think about cases that really didn't need to be done with anesthesia, and those are usually the patients that can go straight to phase two. Kind of the iffy one is lots of places will use propofol for sedation, which is technically a general anesthetic agent, but you need to stop and look at the doses that were used. Is this a dose closer to what you would have used in the ICU for sedation, or is this like the general anesthetic dose, 150, 250 mics per kilo per minute? And if you have any question about your patient, do not send them to phase 2 because you know there's a decreased level of support there. So a couple of scores you need to know. You have the standard and then the modified Aldrete score. And basically, this is kind of a sedation score. So for patients to move on from Pacu, usually they have to have a score of a 9 or a 10. Basic things to think about: how well are they moving? Are they breathing okay? Is their blood pressure okay? Are they awake and are they saturating well? If all those things are present, they're probably back to where they started off. Now, some patients may only be like a 4 or 5 at baseline, so they're probably not going to get any better. But it's good to have documentation of where they were. This is the modified score. Really, the biggest difference here is just some of the values, like the oxygen saturation before was like 92% or 92, 93%. Here, it's a little bit lower. Lots of places will use the modified score for anesthetic patients, but just make sure you know what they're using. So this is kind of how they assess patients in the PACU. And then when they get ready to go home, this is similar, but this is the discharge scoring system. So it pulls in some other factors. You've still got your vital signs and kind of their activity, but it also pulls in like nausea and vomiting. So you try not to send people home nauseated if you can help it. There are times you will have to admit patients to the hospital for refractory nausea and vomiting. Pain is the same way. We want our pain to be controlled and within acceptable limits before we send people home. If you have somebody with uncontrollable pain, do not send them home. It may be a sign of something else going on, either surgically, post-surgically, or an underlying pain issue for that patient. Do not send patients home without controlled pain. And then finally, what's going on at the surgical site. It's common to have a little bit of oozing from a surgical dressing, but you don't want to be sending people home with dressings that are saturated or you've had to change it a couple times. So, again, might be a sign of something going on from a surgical standpoint. Maybe they're bleeding heavily, that sort of thing. Sorry, I was just looking to see if anybody had any questions. So Samantha made the comment of neo bump for the win. When you take your patient out to recovery, it's okay to have those neo bumps in there, but just remember everything you did in the operating room has to come to an end. So maybe you were running them on a neo drip while they were back there. They're probably not going to be able to continue that neo drip and Pacu, and they're certainly not going to be able to send the patient home on it. So a lot of times what we'll do, maybe we had somebody that was doing a prone case, and as part of that, we were being restricted with our fluids because we didn't want a whole lot of edema. Towards the back end of the case, we may need to transition from vasopressors to fluid to try and bring that blood pressure up in recovery. There are definitely times that patients will get neo bumps or on the other end, like labetalol bumps on the way to recovery. But remember, you got to play kind of a long-term game there. One of the things you'll figure out if you're in a facility where you have to manage patients in the PACU is the people that do that will drive you crazy. They drive the PACU nurses crazy too. But there's ways to do it and there's ways not to do it. So think about what you're doing as far as your anesthetic plan goes. So when they get out to phase 2, vital signs are taken about every 30 to 60 minutes. They continue to monitor everything, and they're really just looking for those kind of key things for that discharge scoring system. Most of the medications they give out in phase 2 will be like PO stuff, so they may get like a Tylenol or an oxycodone for the road. They're usually not doing a whole lot of IV stuff because things should be pretty well controlled before a patient gets out to phase 2. So now we're going to talk a little bit about kind of common complications we run into in the recovery room. Biggest things we see are nausea and vomiting and patients that are obstructing. To a lesser degree, you'll see some hypotension, some funny rhythms, some high blood pressure, low blood pressure, cardiac events, and then ultimately some cardiac arrest. But the biggest things that we have to deal with are going to be nausea and vomiting and airway support. So we're all familiar with all the airway structures. The most common thing we see is airway obstruction. Sometimes you will have patients that were doing fine, and for some reason, maybe it's secretions, especially like with facial or dental cases. Like I said, a lot of times they'll start coughing up blood, or maybe you have somebody that's already got a little bit of a reactive airway. So, like, the patient we talked about the other day that's asthmatic may have a little bit of a reactive airway anyways. They smoke, of course, so they get to coughing, and there's a potential for them to get something on their cords and have a little bit of a laryngospasm. We recognize that's not usually a big deal to address, but the other thing you have to remember is you're kind of out of your safe place. You don't have an anesthesia machine right there. So to generate some positive pressure, you're going to have to find an ambu bag. You may or may not have CO2 available. So lots of things that come into play there. Usually as a result of the surgical procedure, there's an increased risk of airway edema or hematoma. So think about like somebody that just had a mass removed from their neck, or maybe they had a thyroidectomy done or partial thyroidectomy, something like that. Those patients are pretty high risk for airway edema and hematoma. They're also high risk for vocal nerve palsy or vocal cord palsy. So a lot of times what will happen on the back end of the case, you may extubate the patient and see if both their vocal cords are moving. You may extubate the patient and have them talk. So you can make sure that, both vocal cords are moving and they don't have any sort of speech impediments. You will see when you get out to the real world that a lot of times people underdose their neuromuscular reversal agents. You'll see that there's people that don't give it to everybody. There are very few ill effects that come from having your patient get, whether it's a Gamedex or neostigmine glycopyrrolate. On the other hand, it's an extremely frustrating thing for the patient and can have some bad outcomes if you don't adequately reverse them. If you've ever seen a fish that was like dropped onto the dock and you know how they kind of flop around, you will see that same sort of thing happen with these patients. And you can imagine them trying to breathe, and that's what they're left with. Obstructive sleep apnea is problematic, as I mentioned earlier. Generally, it's due to anesthesia. They're still weak or they're still sedated. So risk factors for airway complications, usually they're patient-related factors. They came in, they're big, they've got COPD, they smoke, all those sorts of things. It may be pulmonary specific, maybe like pulmonary hypertension, infections, smoking history, or they tend to be a little bit sicker, so they've got a higher ASA score. From the procedure standpoint, any procedures we do near the diaphragm, upper airway, so like thoracic surgeries, ENT cases, those sorts of things can be problematic. Patients in pain, especially if it's pain that's affected by respiration, will not want to breathe. It's just like patients you saw in the ICU with rib fractures. They didn't want to breathe because it hurt. So we've got to make sure we're adequately addressing their pain. Other things you'll see from a procedure standpoint, long procedures, especially long procedures with weird positions. So think about prone or like Steve Trendelenburg. If they get lots of IV fluids while they're in those weird positions, again, you can have problems, airway edema, facial edema, that sort of thing. From an anesthesia standpoint, most of our problems are going to come from patients that had general anesthesia because that's what's really stopped. So if you had somebody that has a spinal or an epidural or even just a peripheral nerve block, usually those procedures were done like an hour, 2 hours in advance. So any complications have probably already been identified. You don't have somebody with local anesthetic toxicity like 4 hours later. But on the other hand, 4 hours after they had their induction of general anesthesia and they're just waking up, you can have problems. Specific things we have issues with, like I said, inadequate reversal of muscle relaxants, over sedation, over administration of opioids. I think this has gotten better over time, but it's still problematic. We've gone from just patients being oversedated or respiratory depressed with straight opioids to adding in things like ketamine and Precedex. A lot of those that give us a synergistic effect. So just make sure you pay attention and figure out who's high risk. Your patient with obstructive sleep apnea is probably not the patient you want still sedated when they get out to recovery. So what causes it? For whatever reason, whether it's oversedation, the patient's disease process, they've lost pharyngeal muscle tone. When you look at them, you will see that they kind of have paradoxical breathing. And what I mean by that is that you see like it's belly breathing, chest breathing, belly breathing, chest breathing. I encourage you to be very cautious about strictly using chest and abdominal movement as your indicator of breathing. Because if you have someone that's had a laryngospasm or they're obstructing, you will still see those things going on, but they won't actually be moving air. So if you have somebody that's on a face mask, or even if they're not, just stick your hand up by their mouth and see if there's air coming or going. If you're not able to tell, you can even take your stethoscope and set it on their mouth to see if there's any air movement. The good news is this is usually pretty easy to treat. All you really have to do is just lift up on that chin. Now, the downside is you have other things to do with your life, so you probably don't want to stand there and hold their chin up all day. So you may consider putting an oral airway in or a nasal airway. Nasal airways are a little bit better tolerated in this patient population. And then ultimately, if this seems like it's going to be going on for a while, you may have to think about putting them on CPAP. Laryngospasms occur as a result of the vocal cords closing, and when that happens, there's no air movement at all. As a result of that, obviously, you wind up being hypoxemic and potentially causing negative pressure pulmonary edema. And we'll talk about that more in just a second. The big causes, for some reason, you've got stimulation of the vocal cords. Like I said, it's usually through secretions or blood. You will sometimes see that overaggressive suctioning can cause it. So when you get out to recovery and that nurse is running the suction catheter way down there, just be a little cautious about that. You can also see that patients have laryngospasms when you've done everything right. So people will be like, well, I don't want to do a deep extubation on my patient because they're at increased risk for laryngospasm. You have risk with regular extubations as well as with traditional extubations. So negative pressure pulmonary edema is a non-cardiogenic pulmonary edema. And what happens is, for some reason, your patient is breathing against a closed upper airway. So it may be a laryngospasm. It may be an endotracheal tube that's maybe been folded over and it's kinked off. It may be that your APL is closed and you forgot to open it. So for whatever reason, they're pulling a large vacuum with that diaphragm against a closed airway. And when that happens, it starts to pull part of that interstitial fluid out of the lungs, and you'll wind up with pulmonary edema. It's not very common, but it will happen. They estimated about 12% of the time. Personally, I feel like that's probably a little bit high. It usually resolves pretty quickly, but the duration of the symptoms or the duration of the event really determines how long the symptoms occur. I've seen more than one patient have to go on ECMO after an anesthetic-related negative pressure pulmonary edema event. Most of the ones I have seen have been patients that got light and bit down on their endotracheal tube. So some people will put bite blocks in there to prevent that from happening. I've seen patients bite through bite blocks. They will shatter their teeth. They'll shatter your bite block. So I think the most kind of proactive approach is just to be vigilant. You know, your patients wanted anesthesia for a reason. Keep them comfortable. From a physiologic standpoint, what happens with laryngospasm is that you get stimulation of the superior laryngeal nerve that causes an exaggerated closure of the glottis. From a symptom standpoint, one, you have to kind of think about where you're at in your anesthetic. Most of these are going to occur on wake up or on your way to recovery. You may hear a little bit of faint inspiratory stridor as they try to breathe that air in. So if you hear normal breathing, it's a bad sign. It's almost like kind of a crowing or, a whistling sound. That's not how people normally breathe. So if that's what you're hearing, start thinking there might be a problem. The other thing you will see is that nothing happens. They're not moving any air at all. So maybe your patient was breathing fine, and then you pulled the endotracheal tube out, and now they're not breathing at all. I'm real quick to throw that mask on there and give everybody I extubate a little bit of positive pressure. I find it kind of helps stretch out their lungs a little bit, and it reduces that risk of laryngospasm. Like I said, be cautious about using either chest or abdominal movement as your sole indicator of respiration. So treatment, if you're in the operating room, get help. Get that face mask on there, get a very good seal. Turn your O2 up to 100% and close your APL. They said 40. I think historically you'll see people just close it all the way. If you do that and you get a good seal, you'll see that you don't actually have to squeeze the bag because you've got that 10 to 15 liter per minute flow that's coming into there. That coupled with the airway pressure being generated by your APL being closed is enough usually to break the laryngospasm. Now, with that in mind, you've got to remember that you will break the laryngospasm, but they're still not going to be able to exhale. So usually what happens is you apply that positive pressure, and then you'll see kind of faint wisp of exchanged air in your mask, or they may start coughing. If they're coughing, they're moving air. It may not be real effective, but that means that laryngospasm is broken. The vocal cords are open. So afterwards, try and resolve whatever caused it. A lot of times, like I said, it's secretions, so suction that out. And then if it continues or you're seeing like an obstructed component to it, consider putting in oral or nasal airways. If you put in an oral airway or a nasal airway that's inappropriately sized, that may be enough to induce that laryngospasm, especially if you have a patient that's light. So lots of times what we'll do is what we call a deep extubation. So you have a patient that has at least a MAC of gas on board or a MAC of anesthetic, and you'll pull your endotracheal tube out. Most of us do this when they're already spontaneously breathing adequately. So keep in mind, you can breathe adequately with anesthetic on board. So tube comes out, and then we put an oral airway in, and then we'll let them wake up from there. If you have somebody that's gone through a long case, it may take them a little while to wake up from the anesthetic. So that allows them to wake up over in the recovery room. If I have somebody that's high risk, I'm not going to do a deep extubation on them, but I will have patients that are high risk. So think about somebody like I had a GI case yesterday that was 500 pounds. He was going to wake up with 2 nasal airways in no matter what, because I knew he wasn't going to breathe very well. So think about those patients. Something else you can do is put pressure on the laryngospasm notch. You may hear it called Larson's point, and it's really back behind the kind of the right where your jaw sits at the base of your ear. So if you think about a little bit medial to the lobe of the ear, just go back there, apply a little bit of pressure, and usually that will be enough to help break that laryngospasm. It's similar to when you would do a jaw thrust, but it's a little bit higher up. So jaw thrust, that as well as the bilateral compression on Larson's point usually will resolve the airway if it hasn't resolved already. When you're applying this positive pressure, remember, like I said, they're not going to be able to inhale or exhale. So you can either apply it for 3 to 5 seconds, then take it off. A lot of times what I'll do is just leave it in place and just roll the mask off, because it's really hard for me to have an extra hand to turn around to open and close my APL valve. So it's easier for me just to roll the mask off. But like I said, whatever you do, just remember that they're not going to be able to breathe with that APL closed. So if you've done those things and you're not able to break laryngospasm, what you're going to see is that they generally desaturate pretty quickly. There's 2 components to that. One, maybe it took us a while to treat it, or 2, we didn't recognize what was going on. So you're going to see that initially they start to desaturate, they become tachycardic if they weren't already, and then as they become hypoxemic, you're going to see that heart rate slows down pretty quickly. That's a bad sign. You'll see it happens a little bit quicker in kids, but when your adult patients' heart rate starts dropping associated with hypoxemia, things are not going well for you. So what do we do? First thing we do is consider deepening our anesthetic if we're not able to break the laryngospasm. So if you have gas on, you may blast them. You may also consider trying to deepen them again, because maybe their airway reflexes being a little too sensitive are what caused this. So consider administering propofol. If they're becoming bradycardic, you consider atropine. But remember, the bradycardia is probably due to hypoxemia. It's probably not a result of any sort of vagal stimulus. So atropine works. The other consideration for atropine is it may help dry up some of these secretions that are causing you problems. And then finally, if you're going to administer succinylcholine, a lot of times in pediatric patients, they'll experience bradycardia just from the sucks. So the administration of atropine may be helpful. Kind of your final 2 things you're going to do if you have a laryngospasm that won't break is the administration of sucks. Usually we do a 1/10 dose. So, if your induction dose of sucks was 200 milligrams, just give 20. If it doesn't break with that, you may have to give a full strength dose and reintubate. The only time I've seen profound bradycardia after succinylcholine administration was with repeated doses. So be very cautious if you have to give more than 1 dose of sucks. The active metabolites will cause you problems every time. It could occur as a result of airway edema or hematoma. So maybe, like I mentioned earlier, result of procedural stuff. So you had somebody that was prone or in steep Trendelenburg, especially if they had large fluid shifts during the case. So maybe they had a lot of blood loss and we gave them a lot of blood products back. Or if you have somebody that got a lot of fluid during the case because maybe their blood pressure was low. So before you extubate these patients, take a look at them. If their face is swollen and their eyes are swollen, they probably have airway edema too. They're not too far physically removed from each other. So be very cautious about extubating a patient with profound facial or scleral edema. So usually what we'll do is prior to extubation, perform a leak test. So suction your airway out, and then you're going to drop the cuff down slowly. And as you do that, you're going to start to hear air movement around the cuff. If you drop the cuff down and you don't hear any air movement, or you have to take over about 50% of the air out and don't hear any air movement, do not extubate that patient, because that's a sign you probably have pretty significant edema around your airway. So hematoma is a little bit different pathology there. Usually the result of, they said neck dissections. Most of your neck dissection patients are probably going to have a surgical airway that stays in place. So it doesn't commonly happen there, but it potentially could, especially if it's kind of a smaller procedure, to where they're going to go ahead and just leave them intubated and then extubate. The most common ones I see are patients that are having their thyroid removed, or patients that have had carotids done. So what happens here is, for some reason, you have rapidly expanding hematoma. Usually, it's going to be like a superficial branch of the artery, whether it's the thyroid or the carotid, and it's going to cause external compression on the glottis. From outside, usually what you'll see is some drainage from the surgical site. Sometimes, depending on the neck case, they will just staple those in place so they're able to get back into the neck quickly if possible. But most of the time, you're going to have some degree of oozing or hematoma that's pretty obvious from the outside. You may also notice that the trachea is deviated, and there may be compression of the trachea lower down. Usually what will happen in these patients is you're able to get an endotracheal tube into the trachea itself, but further down you have a hard time passing it. So a lot of times what you have to do is kind of think about using a smaller airway. So immediate action for this is to decompress the airway by releasing the clips or sutures on the incision. You will probably need to remove the clot, or at least remove the pressure, before you try to reintubate. So the downside of this is they were bleeding from something there. When you relieve that pressure, they're going to really bleed now. And what did I say it was? Usually it's kind of a smaller branch of an artery, so it's probably going to bleed pretty heavily. So a lot of times what you have to do for these patients is, one, try and get the surgeon there, or somebody that has neck surgery experience. So general surgery, ENT, OMFS, those kind of folks at the bedside, so they can try and help get control. If nothing else, you may have to just hold manual pressure there while they're getting intubated. And by hold manual pressure, I mean somebody else doing it, because you're going to be intubating. Get them reintubated quickly. This may be a difficult airway, especially if they've been under pressure for a while. It may also not relieve the pressure immediately. So just opening up the sutures or staples may not be enough. These are the kind of patients that will oftentimes wind up having to have a trach done. You may not even be able to do a crike on these patients because of the hematoma there. So you may have to go a little bit further down and do a trach. And by you, I mean the surgeon, because we don't do that. Vocal cord palsy is usually associated with ENT or OMFS surgeries, thyroids, parathyroids, or airway procedures. You can also see it happen as a result of an overinflated or improperly placed endotracheal tube cuff. So as you can imagine, if you inflated an ET tube cuff in between the vocal cords, that's going to be 30 minutes to a couple hours of pressure on those vocal cords. As a result of that, they may wind up with nerve injury. It can be unilateral. It can also be bilateral. Bilateral stuff is usually a result of airway stuff, whereas unilateral is usually a result of surgical misadventures. If you have somebody with unilateral paralysis, they're often asymptomatic. You may hear a little bit of change in the voice, or they may kind of say it feels weird, or they're talking weird. Bilateral will always be symptomatic. So it usually occurs as a result of the damage to the external branch of the SLN. And as a result of that, like I said, you're going to hear vocal changes because those vocal cords can't tense up. The cricothyroid muscle itself is often paralyzed, or at least very weak. And when you look at the vocal cords, because like I said, a lot of times we'll do an airway exam on these people, when they go to talk, you'll see that the vocal cords are kind of wavy. They're almost like flopping around. If you imagined like you hang up your laundry on a drying rack and the air blowing on it, how things kind of flop around there. So this is just an example of what you may see when you're looking at it. The first one, you notice how the right cord, and by right I mean the cord on the patient's right, not it's on the left side of our screen. Notice how it's taut and that left cord is relaxed. And you may see that when you have them talk, the functional cord will open and close. The paralyzed cord just kind of stays there. And like I said, you'll see that it just kind of flops around. The good news is that bilateral recurrent laryngeal nerve damage is pretty rare, but it can be extremely devastating. You're going to see they're not able to talk. They can't breathe, so they become panicked very quickly, because what happens is those vocal cords kind of get stuck halfway open. And when they take a breath in, it may be enough that through that loss of tone that it will actually close. So then they're obstructing as they breathe in. Extremely scary for the patient, extremely scary for us because we're not sure what's going on. And this is just an example of what I was talking about when you have both sides paralyzed. So can you imagine trying to breathe in through that? Not only that, but because it is so close together, there's a high potential, like I said, when you take a breath in, that it's going to occlude, especially when you're only to get little breaths in anyways. So thyroid surgery has its own complications outside of the hematoma formation we were just talking about. Now, we do a variety of thyroid procedures. Some patients will come in and they'll have a mass on their thyroid, so they may just remove the mass. Sometimes they will just do a lobectomy where they take off one side of the thyroid. And probably most commonly now is that patients have their entire thyroid removed. So one of the things we have to worry about with thyroid surgery specifically is that there's an increased risk of hypocalcemia. Usually it occurs 24 to 48 hours post-op. And the problem you run into with this is that surgeons will usually check a calcium level in the OR and then one in recovery, but nobody remembers to tell their patients about the risk of hypocalcemia when they go home. So, it is, like I said, fairly common to occur in that first 24 hours. Most of these patients have already gone home by then. There are some surgeons through past experience that will make all their thyroid stay in-house, but it just kind of depends on, who you're dealing with and what's going on. Two common signs you'll see, Chostek's-Thyme, which is a facial spasm. So if you stroke the cheek, you'll see that because of that low calcium level, the facial muscles will start to spasm. Or Trousseau's sign, which is like a carpal spasm. So you'll inflate a blood pressure cuff or occlude flow on that side, and it'll result in spasm of the wrist usually. You can also, as I said, see recurrent laryngeal nerve damage or hematoma in these patients. Hematoma formation is usually pretty quick, but one of the things we have to think about is management of the patient's blood pressure and kind of stimulation of the airway. So if you have somebody that's hypertensive, they're going to be at increased risk for bleeding. So especially if your patient is, normal tensive at baseline and we don't manage their blood pressure, or maybe they're in pain or something else is going on, we increase their risk of bleeding. You may also see that they start hacking and coughing. Those things are going to put increased pressure on the surgical side as well. And both of those can lead to a hematoma formation. I've had a couple patients that I cared for. Wasn't my fault, obviously, but went home. One developed an expanding hematoma at home, came back into the hospital in cardiac arrest, had to be criked in the ER, and had a bad outcome. She was fine when she left the hospital, but went home, and I think it was a combination of her messing with stuff and her uncontrolled blood pressure, popped a clot, and she came back in with big hematoma. So just be very cautious. And if you're ever in doubt with these patients, keep them in the hospital overnight. We talked about other cases that maybe we can't control nausea, we can't control pain. If you're not comfortable with these people, see about them staying in the hospital overnight. It's not that big a deal. So we touched on this earlier, but if you're administering neuromuscular blockers to patients, you've got to make sure they're completely reversed. There's very few ill effects that come from adult patients getting neuromuscular blockers. On the other hand, there's a strong potential for ill effects from patients not being fully reversed. So things to look at when you go out and you're thinking maybe somebody is inadequately reversed. So baseline think about train of 4. The downside is usually these patients will have full train of 4, but they may still be weak. So do like a neuromuscular examination on these people. Check bilateral grip strength. Get them to stick their tongue out. Get them to do sustained muscular activity. So ask them to hold their arms up, hold their legs up, sit up. things like that. And like I said, usually what you'll see is they're not able to complete that. They can pick their arm up, but then it just flops down. And then the other thing is, even if the patient's able to do all these things for you, if in your gut or for some reason you think that they have inadequate airway reflexes, there's nothing wrong with giving them more reversal. With the advent of Sugammadex, I've seen multiple patients that got full doses of neostigmine and glycopyrrolate that were weak in recovery, and then got a dose of Sugammadex and they were fine. Now, I think one of the things that's kind of contributed to that is the use of Sugammadex, because we've become a little bit more cavalier with our administration of primarily rocuronium. Before, if we were in doubt or we were getting towards the back half of the case, we would hold off on giving any more paralytics. Now we go ahead and give those paralytics because we know we can just reverse them with Sugammadex. But if you don't use Sugammadex or have like strict criteria about when you can use it, you may see some of these things happening. We talked about it earlier. Obstructive sleep apnea can occur in kind of our high-risk patients. So think about those that are kind of prone to airway obstruction. We're going to talk about a scoring system to evaluate that in just a second. If you have patients that are kind of lightweights, or through body habitus or comorbid conditions, you're concerned that they may be sensitive to opioids, you may consider doing other things to help reduce their postoperative pain that don't involve, kind of global effects. So peripheral nerve blocks may be one of them. You may also consider something like a spinal epidural. And if you have somebody with obstructive sleep apnea, usually we'll try at our preoperative visit to ask them to bring that CPAP with them. If not, you may call ahead while you're still in the case and get the respiratory therapist to bring one over to the recovery room for you. This is the stop bang score. It's useful for determining patients that are at high risk for sleep apnea. So the stop part, do they snore? S. Again, you may not have input from them. You may have to ask somebody else. Do they feel tired or sleepy during the daytime? I'm sure all you guys are hitting the tired one right now. Has anyone ever observed you stop breathing during your sleep? This is obviously a big one. But again, may not be coming from them. You may have to ask somebody they live with or somebody they work with, something like that. And then there's a correlation between airway obstruction and high blood pressure. So if you have somebody that's high blood pressure, that's another pertinent for them. The bang part, BMI, obviously obese patients are a little bit increased risk for airway obstruction. It goes up with age. It also goes up with large neck circumference, which makes sense. You've got redundant tissue there. It's probably going to help obstruct. And then men are at more risk than women. So when you go through and evaluate these 8 points, anybody with a score of 5 to 8 is high risk for obstructive sleep apnea. Intermediate risk, 3 to 4, and then low risk is less than 2. With that being said, you'll see there's very few patients that have a low risk of obstructive sleep apnea with this score. So that's kind of a downside of it. The other thing is all the patients on here that are high risk, you probably already figured out that they were high risk. But this provides a quantitative means of assessing the risk of sleep apnea. Arterial hypoxemia is one of the things that, as we mentioned earlier, is kind of a high risk in the recovery room. So causes patient on room air. Cause of patient being on room air is usually provider being lazy or somebody forgot to hook up the oxygen. So you will go to facilities where even though the policy is to transport the patient on oxygen, they'll say, well, we're just going down the hallway. It'll be okay. Probably not okay. Or it's okay for everybody until you have that one patient where they have a bad outcome. Make sure if you're transporting a patient on a portable oxygen tank, that tank gets plugged into the wall when you get there. Otherwise, they're doing fine for like 5 minutes and then the portable tank runs out. You may also see that this hypoxemia is due to oversedation or too many pain medications that's resulted in respiratory depression. So for whatever reason, they're not breathing adequately. So you may have to consider reversing those medications either with Narcan or Amazicon to improve their respiratory status. The downside is if you're not very careful when you do that, it may be hard to provide the patient pain relief afterwards. So basic treatments, oxygen, especially somebody you wanted to have on oxygen, put the patient on a nasal cannula at first or a face mask, whatever the facility practices. Sometimes patients start off on a nasal cannula and you have to bump them up. You can reverse the opioids, the benzos, like I said. Stimulating the patient is a big one. Usually when we wake these people up, they're okay, but then they go back to sleep and they start desaturating. Something else for you to think about is the positioning of these patients. So we know patients get better pulmonary function if we sit them up. So sit them up, make sure their airway's in a position where it's not obstructing. The other thing you can think about on the back end, and part of the reason I give those patients like a positive pressure breath or just let them breathe against that PEEP for a second on extubation, is to open up all those alveoli. We know general anesthesia causes atelectasis. Now, if you don't do it when you're in the operating room, the other way you can do it is get them over to recovery and have them cough 3 or 4 times, like 3 or 4 good forceful coughs. And a lot of times that'll be enough to open up those airways as well. So all those are things you can consider doing to help out with pure hypoxemia. Now, something else you will see is what we call diffusion hypoxia. So we have patients that we were running on nitrous throughout the case. And at the end of the case, usually we turn off the nitrous. There are some places that they'll wake them up on nitrous, but we turn off the nitrous. And as we do that, you see a rapid influx of the nitrous oxide back into their lungs. And when that happens, you get an artificial hypoxia. So think about the oxygen concentration in their lungs as it plummets as all that nitrous comes back into it. Now, if I had somebody that I was running them on nitrous throughout the case or even extubated them on nitrous, that may not happen until I'm rolling to the recovery room or actually in the recovery room. And it usually doesn't last any more than about 5 or 10 minutes, but you can have a period of kind of transient hypoxia through that diffusion hypoxemia. So just think about that. I think nitrous is one of those things that's almost like a lost art. People don't use it or don't understand how to use it. It's a great gas. You just have to understand when it's okay to use it and when it's not. But it's something else you have to figure out as you get out into anesthesia practice. You may also see circulatory complications. The 2 biggest ones we see are either hypo or hypertension. A fair number of patients will have hypertension after surgery. The biggest thing you have to think about is why are they hypertensive? And what is kind of your threshold for that? Some places will use a systolic pressure of 160. Some places they bump that up to 180. Diastolic's kind of the same way. It's usually 100 or 110. And it's important for you to think about what the commonly accepted criteria is, because when you're writing your Pacu orders, you're going to need to make sure you put in parameters for that nurse to be able to treat it. Lots of places already have in their EMR order sets that may pre-populate it for you. But perhaps you have a patient who's already got hypertension and they've kind of shifted their regulatory curve to where their blood pressure is a little higher at baseline. You may not want to try and bring that patient down to somebody's normal blood pressure if theirs is artificially high to start off with. Biggest thing you have to do is figure out why they have this. Common causes, the most common I think is probably pain. Second most common is probably shivering. So, if you address the underlying cause, a lot of times it will help resolve your hypertension. Other things you may see as people wake up, especially some of our more exciting patients, they tend to become agitated, argumentative, kind of combative. They may not be holding their blood pressure arm still. So you may not be getting an accurate measurement. A lot of times before I treat somebody for hypertension that didn't have any hypertension before, I'll actually go lay eyes on the patient, cycle a blood pressure while I'm standing there and see what it looks like. Because you don't want to be treating hypertension that's not really there. And then they calm down and all of a sudden, their pressure's in the toilet and now you've gone to the other extreme. Because the first thing that's going to happen is they're going to blame you treating the hypertension for causing the hypotension. Another cause that people overlook a lot of times is urinary retention. So intraoperatively, patients will have a Foley placed. Usually it gets pulled out before they go to the recovery room. But when they get over there, they may have a hard time voiding, especially if you get males that are a little bit older, hitting 50, 60, 70, where they may have some prostate issues. It may be harder for them to void. With that being said, especially if they're not able to wake up, they may become, a little confused. Their blood pressure may creep up because they're in pain. They need to void, but they're not able to do it. So think about things kind of outside the normal may be causing your hypertension. You can also see the same thing with bowel distension, but it's not quite as common. So depending on the case and kind of what's going on, you may come up with a range to keep the blood pressure, or if you're dealing with blood pressure that may affect surgical sites like neuro patients or vascular patients, the surgeon may specify where they want to keep their range. So like I said, they may want to run it artificially low to reduce the tension on the vessel to decrease their risk of bleeding. So first of all, think about the underlying causes. If you're not able to address those underlying causes or you've already taken care of all of them, then consider using rapid acting medications. The most common by far is labetalol. Usually we'll administer it in doses of 5 to 10 milligrams. There's not a max, it's patient specific. But if you keep giving the same medication and you're not getting any results, consider something else. Other factors for you to look at is kind of the big picture. Don't just get fixated on their blood pressure. You also need to pay attention to their heart rate. So if I'm giving labetalol or metoprolol, I know that I'm going to bring their blood pressure down, but I'm also going to bring their heart rate down. So if you have somebody that's already bradycardic or kind of, 60s lower end, you may consider avoiding a beta blocker and go to hydralazine instead. And usually we'll dose that like 5 to 10 milligrams at a time. The thing you have to remember if you're using hydralazine is it's not quite as fast acting as labetalol or esmolol. So don't redose until you've waited like 15, 20 minutes to make sure that it's actually worked, because otherwise you'll start getting all those doses piled up in there. And again, now you're dealing with low blood pressure. You may also see hypotension on the other end of things. And we kind of have to break that up by what's going on with the patient. Probably the most common we see is a hypovolemic shock, resulting in decreased preload. This may occur as a result of excessive NPO time. It may be a result of blood loss. You'll see a lot of times in the operating room, people are hesitant to address blood loss because you get pressure from the surgeons. If every time Dr. X does a hip replacement, his patients have to get transfused, the hospital starts noticing. And they want to know why the other 4 joint surgeons don't have to fuse their patients and his do. So you may receive pressure from them to not transfuse the patient. You may also see that this is a distributive issue. So think about somebody that's coming in, maybe they've got a kidney stone. As part of that, they've been sick for a little while and they've got sometimes even just frank pus backed up behind that stone. They go to the operating room, they do lasers, they put in PCNL tubes, something to break up that stone. And as a result of that, you kind of get widespread infection spread. So all that pus has now gone systemic. As a result of that, you may see that they've become profoundly vasodilated, so they've lost all their afterload. You may also see that in patients with spinal shock. So think about a trauma patient that was a car accident. Maybe they had a positive FAST exam, or they had a CT that showed they had blood in their belly. So then they came up to the operating room to address that. They have a cervical collar on still, or somebody happened to mention that, there may be a cervical fracture. As they progress, they may see some cord edema. So as that happens, you tend to have systemic vasodilation as well below the level of the lesion. Or this may be a cardiogenic factor. Maybe they had cardiac problems beforehand, or maybe it is occurring as a result of something that happened intraoperatively. So maybe that's a patient that had an MI while they were in there. So other things that'll cause that decreased preload, we mentioned ongoing bleeding, but you may see that your patient has third space. Maybe we thought we had adequately resuscitated them with crystalloids, but we hadn't. Or for some reason, we just didn't give them enough IV fluid replacement. You may also see, and this is kind of a relative hypovolemia, more of a distributive problem, that if we have somebody that has a spinal or an epidural that's put in, you lose sympathetic tone. And when that happens, everything vasodilates. So you have a relative hypovolemia that occurs because their vascular system has suddenly become very large. So those patients need to be preloaded or co-loaded with fluid. And then we mentioned ongoing bleeding. From the distributive standpoint, biggest causes you see, like I mentioned, were sepsis. Other things to think about, and usually you detect this before you get to recovery, potential for allergic reactions. But sometimes what you'll see is that you have minor allergic reactions to the point where we don't recognize it because under anesthesia, it may be hard. The only symptoms you may see are that they've got a little bit of a rash, but you can't see that because they have drapes everywhere. So then you get to recovery, the drapes are down, and you start looking at them, you're hooking up monitors, and you realize they've got a rash on their chest. Well, they're also a little tachycardic, and their blood pressure stayed on the low side, their sats have stayed on the low side. Things like that, you have to start thinking there may be a little bit more going on than what you realized. Other things for you to think about, we deal with some really critical patients, some of which are very fragile. And as a result of that, you may see that small doses of medications can have very exaggerated effects. So as I said before, like when we were talking about labetalol, give a little bit and see what happens, and then you can always give more. When we give you dosages for medications, they're really a starting off point. They don't take all the patient factors into account. So you may have to kind of reevaluate what's going on with those patients. So allergic reactions, as I mentioned, are one of the issues that you may encounter either intraoperatively or postoperatively. We primarily use epinephrine as our drug to treat these. Usually it's going to be low dose IV epinephrine. So, think about like 10 to 20 micrograms, which seems like a very low dose. But when you start thinking about how much you were giving subcutaneously or IM, like 0.3 to 0.5 milligrams, it's 300 to 500 micrograms. But because those patients had delayed systemic absorption through their vasoconstricted tissue, sub-Q or IM was not nearly as reliable as IV. So again, start off with low doses, 10 to 20 mics, and then you can give more. Things to remember, common cause of drug reactions, most common being muscle relaxants. So usually this doesn't occur in recovery. It's usually something that happens at induction. The downside is, like I said, a lot of times we won't recognize it. Other things for you to think about, patients that may have latex allergies. A lot of times our products now are latex free, but not 100%. Sometimes they'll slip through. So make sure if you've got somebody that's high risk for a latex reaction, healthcare providers, patients with spinal bifida, that sort of thing, that you've tried to eliminate all the latex from the room. Antibiotics can cause reactions as well. We have a lot of patients that come in and say they're allergic to medications that really aren't. So sometimes what we will do is give a small test dose of a medication. The downside is the patient's under anesthesia. A lot of times we can't see the symptoms anyways. So fortunately, giving test doses doesn't usually cause problems. Unfortunately, you give so many medications in a short period of time that you probably wouldn't recognize it. And then finally, there are other medications that patients are allergic to, but most often their allergic reactions are not really anaphylaxis. It can happen, but usually it's more of a side effect of the medication. I got Valium and it made me sleepy, or I got morphine, fell asleep, or I was tired. Itching is kind of common with morphine, especially neuraxial administration. So like I said, neuromuscular blockers are one of the most common ones. The biggest thing you're going to see is that histamine release that causes vasodilation. So remember, your patient can't talk to you. You may notice that your blood pressure drops precipitously. As I said, usually it occurs around induction, so you've probably given them a medication in there that also causes hypotension. You may see their heart rate goes up along with that blood pressure going down. They can't tell you they're itching, but you may notice that there's a rash. So if you have a patient that experiences hypotension and tachycardia, try and get a look at their chest, their back, their arms, stuff like that. Underlying what's going on is that they're having some bronchial constriction, so you may see that your airway pressures go up as well. So even though it's hard to figure out with one thing, if you start looking at the big picture, you may notice that a lot of these things are kind of coming together. Like I said, latex allergy, think about your high-risk group, so patients that have had multiple surgical procedures, patients that are healthcare providers, or patients with spinal bifida. And most of these latex allergies are more of like contact dermatitis type stuff. They're not full systemic reactions. With antibiotics, penicillin's the most common one. Vancomycin gets blamed for having an allergic reaction, but it's not usually an allergic reaction. It's that direct histamine release through rapid administration. So people are usually not allergic to vancomycin. It's because somebody oopsed when they were giving it. Manifestation, same thing, pruritus, flushing, urticaria. With severe reactions, you may see angioedema, bronchospasm, hypotension, and death. You will see that with IV administration, it's generally a little bit more potent of a response than like PO administration. We talked a little bit about sepsis and the problems that come along with that. The most common patients we will see experience hypotension or cardiovascular collapse in the operating room are going to be urinary tract procedures or like biliary tract procedures. So people with gangrenous gallbladders are high risk, and then patients that have stones. Primary treatment is going to start off with fluid resuscitation, but very quickly move to vasopressor support for these patients. We kind of get cavalier with kidney stones, especially because you think about it, well, it's just a cysto or it's just an S-wall, but you never know what's growing behind that stone. So always make sure if you're doing kidney cases, you've got pressors available. From a cardiogenic perspective, this may be an acute event. They may be having an ischemic event. They may be having an MI while we're watching, or this could be kind of an ongoing condition. Maybe you had somebody that has a chronic pericardial effusion that's being exacerbated by their current condition, the surgery, or it may be as a result of dysrhythmias. So maybe you have somebody that has gone into AFib that we thought was a chronic condition, but it's really an acute condition. And as a result of that, they've lost that preload. So they may be having some cardiac issues related to dysrhythmias. You may see it happen with ventricular ectopy as well, but it's usually as a result of the atrial loss, because patients with like widespread ventricular stuff, it tends to stand out pretty significantly. They're having long runs of VTAC, stuff like that. So the biggest thing we can do is figure out who's high risk for cardiac procedures. And this is what we usually use for that, the cardiac risk stratification procedures. So it kind of makes sense. Patients that are having major vascular surgery or cardiac surgery are probably high risk. If they've got bad peripheral vasculars, they probably have bad cardiac vasculars as well. Same thing continuing down to kind of less intensive cardiac stuff, carotids, other head and neck surgeries, or just other big surgeries. So belly surgeries, head and neck surgeries, big orthopedic stuff. And then finally, low risk is, things like cataracts, GI stuff, breast surgeries. So things to look at as far as determining your risk of myocardial ischemia. Make sure that your patient is continuously being monitored in the Pacu. This really comes into play not so much in traditional general anesthesia, but patients that are maybe at a GI center or maybe having cataracts done, stuff like that. Make sure you've got multiple leads. You want to make sure that the 2 leads that are visible on your monitor are lead 2 and lead V5. Those tend to be the most sensitive for determining the occurrence of ischemia. Other things that will help you out, most of our cardiac monitors now have computerized ST segment analysis. So when that alarm starts going off, think that maybe it's real. Lots of times we just hit silence and adjust our limits. But if you had somebody that had no ST segment changes before and their leads haven't moved, you probably want to pay attention to that alarm when it starts going off. If you suspect something's going on, first of all, get a detailed assessment of your patient, but make sure you get a 12 lead pretty quickly, and then work on getting cardiac enzymes. If you have somebody that experiences or possibly experiences a cardiac event in the recovery room, you want to make sure that they're going to be admitted and followed. You can start things moving, but you really want somebody that specializes in this, kind of following the patient into the hospital as well as treating and evaluating them. So sometimes you'll be the one calling cardiology. Other times what will happen is you call that hospitalist that's covering the PACU, and they'll take over management and follow the patient and get them admitted. Other things for you to think about, causes of myocardial ischemia. So try and do what you can to improve the patient's condition or avoid this from happening. So, we know tachycardia can cause a decrease in our oxygen supply, overall decrease in our oxygen content. So somebody that's got a low hemoglobin level or is not getting adequate supplemental oxygen can be problematic, or factors that'll help reduce coronary flow, so hypotension or increased cardiac resistance for some reason. So try and avoid these conditions as you can. Causes of dysrhythmias, the biggest one we see is hypoxemia. Usually it starts off causing tachycardia, but it may go on to cause bradycardia. Hypoventilation a lot of times will go hand in hand with that. You may see that for either surgically related or patient related that they're having catecholamine surges. So that may be leading to tachycardia. You may see that there's electrolyte abnormalities, maybe because of the patient's underlying condition. Maybe they missed dialysis. Maybe we didn't know that their K was high to start off with, or because of something that happened intraoperatively. Maybe we gave them large volumes of blood or gave them electrolytes. So if you're having dysrhythmias, make sure you get a chemistry panel. A lot of times our point of care ABGs will not have magnesium levels on them. And magnesium will help out with a lot of your cardiac arrhythmias. Other things you may see causing dysrhythmias, if your patient is anemic, you may notice that they're tachycardic and then later bradycardic, and then the same thing with fluid overload. They may be tachycardic and later bradycardic. So just reviewing a couple common dysrhythmias, the biggest one we see is sinus tachycardia, just an elevated heart rate. It may be totally normal for the patient, or there's lots of different things that can cause it. Sympathetic stimulation, pain being a big one. If you're not addressing pain, your patient's heart rate's going to go up. If they're hypovolemic, it's pretty common to see that they're tachycardic. If they're anemic as a result of blood loss during the surgery, again, they'll be tachycardic. If they're mad, they're angry, they'll start to become tachycardic. And then finally, if they're shivering, they'll also be tachycardic. So when this is going on, like I said earlier, the biggest thing is you've really just got to address the underlying causes of it. From an atrial standpoint, like we talked about last week, it's pretty common to have atrial dysrhythmias during or after cardiac or thoracic surgeries. Big risk factors, pre-existing cardiac risk factors, so somebody that was high risk already, patients that are fluid overloaded, electrolyte abnormalities, or patients that are not receiving an adequate amount of oxygen. So when we start looking at AFib in these patients, the first thing we really got to figure out is this a new rhythm or is this an old rhythm? And then you have to start thinking about what you're going to do about it. If this is a pre-existing condition, a lot of times our treatment focuses on getting the patient into a rate-controlled state. So they're no longer just an AFib, they're now having a rapid ventricular response to that atrial fibrillation. If this is somebody that's in new onset AFib, we probably want to see about getting them converted back to their original rhythm. If they're unstable, that's going to be done through chemical or electrical cardioversion. If they're stable, most of the time, this is going to be done through beta blockers or calcium channel blockers. Again, make sure that you're getting either the hospitalist or cardiology on board so they can make recommendations and follow this patient. From a ventricular standpoint, the biggest thing you'll see is like Y complex stuff. So it may be PVCs. A lot of times the cause of PVCs is just cardiac strain or a little bit of hypoxia. Most of these patients are not going to have true VTAC, and if they do, it's usually a result of underlying cardiac disease. So if you start seeing like ventricular arrhythmias, start evaluating those H's and T's, just the same ones that you were thinking about with somebody in cardiac arrest. Are they hypoxic? Hypoxia and hypovolemia are, again, the biggest two reasons it's going on. Is this some sort of tamponade? Do they potentially have a clot somewhere, whether it's pulmonary or cardiac? Is this an overdose? Is this an electrolyte abnormality? Those are the things you really have to look at that are causing these dysrhythmias before you can treat them. Bradycardia, everything can cause bradycardia. The most common ones we see intraoperatively and postoperatively is going to be hypoxia, late hypoxia. Other things that will cause it, abdominal pressure increasing, ICP increasing, increased intraocular pressure, and then spinal anesthesia, a lot of times through that sympathectomy, will also cause bradycardia. So what you'll see with those spinals, even if you do everything right, sometimes your patients can develop high spinals. Usually when they start reaching like the high thoracic level, you'll get a block in your cardiac accelerator fibers, and that's going to result in profound bradycardia. And what you'll see in those patients is a combination of the bradycardia, the sympathectomy, and intravascular volume loss because of that vasodilation can result in cardiac arrest, even in young, healthy people. That's why even if we're doing spinals on older folks, we try and co-load or preload them with IV fluid. So we've got a little bit of a cushion there. Other things that can cause it, inappropriate dosage of medications for spinals or patient anatomy as well. And kind of the last thing we're going to talk about here is postoperative cognitive dysfunction. So delirium is kind of an acute change in the patient's condition that can't be attributed to something else, or like acute intoxication or medication. With that being said, there are pre-existing medical conditions that may not necessarily contribute to it, but may coexist with delirium. So like patients that are a little bit older, we know have an increased risk of postoperative cognitive dysfunction. You may also see that as a result of certain surgical procedures that they're at increased risk. Sometimes immediately after the surgery, it's really hard to tell if this is a cognitive dysfunction, or is this somebody that's still coming out of anesthesia? So specific risk factors: age greater than 70. If you had somebody that had a cognitive impairment at baseline, anesthesia is not going to make it better. So they're increased risk post-operatively. Patients with decreased functional status, so think about bedbound nursing home patients, patients that have been in the hospital for a while, are also at increased risk. And then those with alcohol or other substance abuse are increased risk. We can't do anything about these factors. You just need to know these patients are at increased risk, and we try and avoid things that will make it worse. So intraoperatively, there are some things we can control. Patients that have significant blood loss and are allowed to bleed down to a crit less than 30 are bad. But with that being said, if they have to have multiple intraoperative transfusions, that's also a problem. Now, it's a problem because they had increased blood loss, but it's definitely a risk. Hypotension can be problematic. Delirium may occur as a result of CVA. So if you're not adequately perfusing your patient intraoperatively, it can result in stroke. Administration of nitrous oxide has been implicated in increased cognitive delirium issues. And then patients that get general anesthetics are at increased risk versus those that have regional anesthetics. Unfortunately, the patients that already have like preoperative cognitive dysfunction may be very hard to do a spinal, epidural, or regional because of their cooperation level. So how do we manage these patients? First of all, figure out who's high risk prior to surgery and formulate a plan that really helps us avoid triggering agents. You may see these patients if they're severely agitated, may require additional assistance in PACU. There's a fair number of facilities, I don't know what it's really called, but it's almost like a spiderweb type cage device that they may put some of these patients in post-operatively. I think it was probably intended for kids at first. But you'll see adults put into it as well. They may need to have like a one-to-one sitter in addition to the PACU nurse. But figure out these patients early on. Try and design an anesthetic plan to avoid triggering stuff in these patients. You will also see, and it seems kind of counterintuitive, but if we take these patients that are older and get them in and out of an outpatient center, they do a little bit better. The downside is those older patients tend to be a little higher risk and are not done at those centers for that reason. So you kind of have to find a fine balance between doing them there and not having a bad outcome because of the cognitive issues. So if you have somebody post-operatively that's taking a little while to wake up, it could be a cognitive issue or it could be any number of things that lead to delayed awakening. So take a look at their vital signs. If you have somebody who has a high end-tidal CO2 level, they're going to be sleepy. So you've got to make sure that they've got good pulmonary function, especially if you've got somebody that's had volatile gases, because it's going to take a little while to blow them off. If they're able to cooperate, do a very detailed neurological exam. If they can't, at least look for basic things like, are they moving all their extremities? Do they wake up? If they smile, is it symmetric? Check grip strength, motor strength, that sort of thing. Keep an eye on their oxygen status. If you have somebody that's taking a while to wake up, you probably want to go ahead and get an ABG on those patients. Another thing to kind of keep in the front of your mind is the potential for glycemic changes. So maybe you had somebody that you didn't realize was diabetic or didn't get passed along. Get a blood sugar on these people pretty quickly to see if it's low. If you've kind of gone through those basic things, think about getting a CBC, maybe their hemoglobin's low, or look for electrolyte abnormalities as well. The biggest cause of delayed awakening is residual sedation from the anesthetic. So if you've got somebody you're concerned about delayed awakening, don't use long-acting agents. Use things that you can get rid of pretty quickly. Other things you'll see, if it's a result of opioids, you can go through and reverse it. Start off with very low doses of naloxone. This isn't like giving the 0.4 or 2 milligrams you gave when you were an ER nurse. We don't want these patients fully awake because we want them to be comfortable still. And if you go through and saturate all the receptors with Narcan, they're no longer going to be able to have that pain relief, or it'll have competition. Benzodiazepines, same thing. Start off very slowly. 0.2 milligram dose, but be very cautious about repeating that. You'll also see, I hate scopolamine personally, but I know there are people that think it's great. Old people and scopolamine do not mix. So if you have somebody that's a little bit older or somebody that you think is not waking up quickly because of scopolamine, you can treat it with visostigmine very slowly, and it'll help reverse some of the sedative effects. But just be very cautious with scopolamine in these people at all. Other things that you see cause delays in waking up: cold patients don't wake up very well. They also have altered metabolic processes. We touched on hypoglycemia before, so make sure if you've got somebody that's got a low blood sugar, you catch that. Elevated intracranial pressure may be a problem, or just CVA in general. So we try and rule out the quick things, and then if they're still not waking up, start thinking about the bad things. So stroke is definitely a possibility. If you had somebody that was increased risk for ICP being elevated before, that may be what you're looking at, is for some reason intraoperatively it's gone up. So if you do have the capability, make sure you're monitoring that. And then again, like we've talked about, making sure that you've had adequate reversal of neuromuscular blockade. So this is just kind of a quick list. We talked about that Pacu discharge score, but these are all overall goals. Somebody needs to be awake and oriented or back to their baseline mental status before they go home. It needs to be somebody that didn't have a minimum mandatory stay. And what I mean by that is like the vascular patient I talked about earlier that had to lay flat for 4 hours or 6 hours. Vital signs need to be stable and within acceptable limits or back to their baseline. You need to have a set criteria. You don't want people kind of subjectively determining who should go home and who can't. Using scoring systems is very helpful. So one of the things that for a long time was criteria was people had to be able to tolerate PO and had to avoid it before they could go home. If you have somebody that's dry, they may not be able to avoid. But with that being said, you need to make sure that they understand if they get home and they can't tolerate PO, or they're not able to avoid, that they contact you because they may need to come back in. As we talked about earlier, urinary retention can be problematic either as a result of the medications or the Foley. They need to go home with an adult. The adult doesn't necessarily have to drive them home. We're seeing people that are in situations, live in cities, don't have cars available to them, that maybe they're taking an Uber or Lyft home, but there needs to be an adult that stays with them. It's not the Uber driver drops them off at the door. So somebody needs to be with them, usually for about the first 24 hours. Make sure they're getting written instructions as far as, post-operative follow-up, diet, medications, and probably most importantly, how to get in touch with somebody if there's an emergency and to call 911. And this is just a quick look back at that discharge score. So what questions do you guys have?